Welcome to Black Health Matters. I'm your host, Darryl Armistead. This is a Howard University Hospital transplant support group session led by Dr. Clive Callender, who is a noted transplant surgeon and professor of surgery at Howard University College of Medicine. Let's join today's session in progress.
Group, because it all depends upon whether you talk about it from a retired person's perspective, because they start sending us information at the age of 50. But as Dr. Spoke to us about last week, traditionally they talk about 65 and over. But I like to think of us as 50 and over, because that's when the retired persons people start communicating with us about joining the AARP. I don't know how many of you have not received a communication from them after the age of 50, but I guess most of us have. So she's in the process of joining us.
When I got that first communication, I was heartbroken.
Which communication?
From AARP. He said, "Yo, not me."
Then after a while, you appreciate it. It's great to be here.
They give a lot of great information. Yeah.
Before we get started, I wanted to share something. My granddaughter, Kayla, who used to attend frequently when we were at Howard with our meetings, graduated from Penn State this weekend. Oh. So I'm really excited for her, and I just wanted to share it.
Wonderful. Yeah. Well, we're excited to hear about that. When does her brother finish?
He hasn't. You know, he went through that program at PG, Community College, and you graduate with an AA. And then he went on to Towson for his junior year. Then he went back to Towson for a semester. Young folks. He's doing something he likes doing, something with home development firm or something. Of course, as a parent, Chris was very upset. A couple of semesters you could have finished. And I think he will in time. He's happy. He said, "Mom, I'm making money. I'm okay." I mean, what can you do? You got to let it go. Kayla has a job. I'm excited about that. Dr. Callender, she's moving to Dallas, Texas.
Oh, okay.
Yeah. So, yeah, both of them are doing well. All three of them are. I'm proud of them. Mm-hmm.
Yeah. Glad to hear. Haven't seen Chris in a while. So
yeah.
Well, since we're sharing things, my great grandson graduated last weekend also from the University of Southern Alabama, and he graduated. He got his master's degree in cybersecurity.
wow.
So we all told him now that he is finished being a professional student. It's time to get a job.
Yeah. Yeah.
But he has a lot of prospects, and we're just happy for him getting his master's at 23 years old.
Well, you know, that field is wide open.
Yeah.
Well, while everyone is sharing, I guess I might as well share too, that my third great-great-granddaughter just got accepted to, just coming out of McKinley High School this year. That's my alma mater. Just got accepted to North Carolina A&T.
Amen.
As I said, that's my third great-granddaughter. I have my second great-granddaughter is at Kent State. She just finished her first year. And my first great-granddaughter came out of Delaware State in 2025. And
Mhm.
that's the mother now of my great grandson.
Whoa.
So that makes
Congratulations.
me a little old lady.
Good.
Yeah, okay. Well,
Mhm.
that's great news. Great
Yeah.
news. Um, let's see. Pamela has joined us, but I don't see her. She's still muted to us.
With so much going on today, it is certainly good to hear good news. Thank you all.
Mhm. Yeah.
That's so true.
Mhm.
Yeah. Yeah, we've all been blessed to be around and to have our children and great grandchildren and
Yeah.
grandchildren to be doing so well. We are all
Mhm.
very blessed.
Yeah.
So I get to know about everybody. Who has the most children on this panel?
We did that in church. They
Back
got a
to church.
prize. They got a
Uh-huh.
prize.
Who has three?
I do.
Who has four? Okay,
Well, if
so
I count my steps, yeah.
Dr. Coleman.
okay.
Coleman, you ready now?
Yes, good morning, Dr. Callender. I'm just going to share my screen next. Well, should I do that next, or are you guys ready for me, I guess?
Okay, all right, Dr. Coleman. We're fortunate and blessed that Dr. Coleman is taking the time to join us to educate us again about the urological concerns of people who are above the age of 50. And a lot of things going on urologically, new developments. And so I wanted her to give us an update in terms of where we are. Dr. Coleman has been so busy of late with being president of the medical staff and so many other hats that she wears that we're blessed that she could join us today to educate us about how we can, in our blessed years of 50 and beyond, can live healthy, qualitatively great years. So, Dr. Coleman, thank you for joining us today.
Mhm.
Thank you, Dr. Callender, and welcome to everyone. Let me just,
She may be having network issues. She's muted now. The screen looks like it's frozen. Okay, but she's muted. You're muted, Dr. Coleman. There you go. Oops.
Yeah.
Dr. Coleman, you're still on mute. You have to unmute so we can hear you.
Mhm.
but on the right,
Mm-hmm.
click the line to minimize. Yep. Okay.
All right. Good morning. Can you hear me?
Yes.
Okay, great. Thank you. Sorry for this technical difficulties, but let's get started. So again, thank you very much all for having me today. Thank you, Dr. Callender, for your welcome. So my topic is recent advances in urology, sexual health, hormones, and healthy aging after 50. Uh-oh, how can I advance? Um, hmm. Oh, okay, here we go. All right, so my objectives today would like for you all to get a clear understanding of some common urologic changes after 50. Learn about menopause and hormonal health, discuss sexual wellness in men and women, and understand newer medications and treatments that are available. We'll talk a little bit about over-the-counter supplements and medication safety, which I think is very important, and learn some healthy aging strategies. I don't have any relevant disclosures for this presentation. So why this topic matters? Well, quality of life matters, of course, right? All of us, many adults over 50 experience a lot of these problems that I have listed here. Menopausal symptoms, and we can see menopausal symptoms, believe it or not, in both men and women. And men, we would call those andropausal symptoms. Sometimes men will go into andropause where their testosterone is lowered by medication that we may put them on for a disease, for example, prostate cancer. Erectile dysfunction. I'm going to talk about erectile dysfunction not only in men, but sexual desires in women. The effects of low testosterone level, vaginal dryness, urinary leakage, fatigue, weight gain, sleep changes. Sleep is so important. I think a recent study came out showing that we should be getting at least 6 to 8 hours of sleep. Now, sometimes our bodies are already sensitized to waking up at a certain time, and it's just been doing that for the last 60 years. It's maybe difficult to change that pattern. And taking naps in a day is not bad, but sometimes when you take naps, it interferes with your sleep pattern at nighttime, and then reduce libido. But what I really want to keep in mind, and I will have key messages at the bottom of most of the slides, that these are common medical issues and they are very treatable. So let's talk about looking at the system, urologic changes after 50 that affect the urinary system. So in women, menopausal changes. Let me direct you to this diagram here on your right of the screen. It's just showing just some basic anatomy. So here we have female, our kidneys are the same, the urinary tube, the ureter drains the urine down to the bladder. And this is where we see the differences. So in women, the bladder has a short urethra connection out to the rest of the vaginal skin and with urination. In men, the system is still the same. I should stop here. Adrenal glands, which make hormones, both the same in men and women, the ureter, the bladder. But what's different in men, the prostate gland. You see the prostate gland basically encircles the urine tube called the urethra, which is longer in men going throughout the penis. And this prostate gland being here can present some challenges that we'll see in men over 50. Primarily enlarged prostate, testosterone decline, which testes now, the testosterone is coming from the testes for the most part, which is not shown in this picture down the scrotum, but also testosterone can come from this little gland above the kidney, which is called the adrenal or adrenal gland, okay? And then erectile dysfunction. So, but in both men and women over 50, there's overactive bladder that sort of gotta go, putting the key in the door and you're rushing to get in the door and your urine's starting to come down. And it's like the bladder has actually taken on a mind of its own and decided that it's going to start to leak urine even though you're not in the bathroom, or incontinence. So incontinence, involuntary control of urine, or it could be also a feces also. Kidney stones are common to both men and women. This is one thing people say, oh, you're a female urologist. Yes. What do you do? Different from OBGYN, but I don't deal with babies. I don't deal with OB portion, but in the gynecological portion of women, I mean, we can get kidney stones. Urinary tract infections are more common in women. Again, back to this anatomy, the bladder and the short urethra here. So bacteria that commonly would be decreased in the vagina due to the estrogen effect can make their way up the short urethra into the bladder and cause infection. Or we talked about, I know everyone just talked about with everyone wiping from front to back and not coming forward. But if there are these live bacteria, they can easily make their way into the bladder. But we do see urinary tract infections also in men, especially as they get older and their prostate gland maybe doesn't necessarily have to be enlarged. It can be small, but it can have an effect here on the bladder opening, causing bacteria not to be washed out of the system, to stay in the bladder and to grow and cause infection. Sleep disruption, of course, common to both men and women, and sexual dysfunction. Now, these are symptoms that you should not ignore, should not be ignored. And some of these warning signs very commonly. So anytime you see gross blood in the urine, redness to the urine, pinkness to the urine, this is something that you should not ignore. And where do you go? You find out, you seek out your primary care doctor, who may also maybe refer you to a person like me, a urologist or urogynecologist. Frequent urination, this can be a sign of a lot of things. Urinary tract infection can cause frequent urination. Diabetes can cause frequent urination. Enlarged prostate glands, bladder prolapse, these are all things. So what's frequent urination? If you think about it, we really should urinate 6 to 8 times a day and not get up more than twice a night. Now we'll give a little bit of leeway. Sometimes we say not more than once a night in younger patients, but certainly not more than twice a night in an 8-hour period. Now, if you went to bed and only slept an hour, you shouldn't be getting up during that time period. But that's frequent urination. Perhaps some of you might think, wow, 6 to 8 times a day. Yeah, if you're drinking adequate amount of fluid, that's how much you should be going. Our bladders are not meant to be like camelback sources. We're not meant to carry fluid, through the whole day. We are meant to empty about every 2 to 3 hours. Any type of leakage of urine or stool or both is a warning sign not to be ignored. Don't just think about going and buying the Depends. The Depends, yeah, you can depend on the Depend, but you don't know what's causing you to depend on the Depend. So you really want to go and get an evaluation. Urinary undergarments are there for people use them for protection, but you should be evaluated first. I will say we cannot necessarily cure all incontinence problems. So sometimes people do need to wear a urinary undergarment, but you should be evaluated first. It doesn't mean that you have to, that's your only resources to wear some type of pad. And again, this goes for both men and women. We see incontinence problems in women, but certainly in men, certainly after prostate surgery, for example, incontinence problems may become manifested. Any pain with urination, the urine coming out shouldn't be painful. If it is, this may be a sign of a very classic sign I tell the medical students of urinary tract infection or dysuria, pain with urination. Painful intercourse. As you'll see as I go through the presentation, I mean, intercourse is a healthy sign of healthy activity as we grow older, but it shouldn't be painful. We'll talk about primarily, we'll talk about women in terms of vaginal atrophy, and the reason for its painful intercourse. And even sometimes in men, I'll show you disease called Peyronie's disease, which can causes scarring in the penis and can make intercourse painful. Erectile dysfunction in both men and women, fatigue, slowing down, not having the usual strength, could be a sign of a number of things. Maybe low blood count, anemia, maybe medication side effects, maybe that you're not getting enough really true restful sleep. You're not into a REM sleep, rapid eye movement sleep, which is when we're dreaming, and that is the kind of the best sleep that you can be in. Pelvic pain of any sort in both men and women, uncomfortable pain, that's another warning sign that should not be ignored. And then if you have a family history of urological conditions, hopefully we're getting more used to being able to have a frank discussion with our family members about what conditions may have existed in the past. If they can give us an idea that, the fruit doesn't fall far from the tree. So some of these sometimes are just genetic that we may find ourselves having to deal with. But it's good to have an idea of family history. So the key message here is that early evaluation can save lives. So I'm going to talk first about women's health, and then we'll move through to men's health. The women's health section, we're going to go over these mentioned here on the slide: menopause and bladder health, genital urinary syndrome of menopause, or GSM, has its own separate section now. Woohoo, ladies, right? In the AUA guidelines, we have guidelines for treatment, not just for men in erectile dysfunction, but also in genital urinary syndrome of menopause. There's some new treatments for menopausal symptoms, female sexual dysfunction, and treatments of low libido in women. So first here, I don't know if you experience this, menopausal changes. It's actually more than just hot flashes, but certainly hot flashes is big there. What is this? What's the cause of this? Well, lower estrogen. Lower estrogen affects vaginal tissues. Estrogen is a hormone that is produced primarily by the ovaries, but small amount can, in that adrenal gland that I showed you above the kidneys, produce estrogen. And this is important in vaginal tissue health. The estrogen around the vagina does a couple things. One thing, it keeps the vaginal tissues moist and lubricated so that there isn't the vaginal dryness, which might lead to uncomfortable sexual activity. Bladder function and also prevention of urinary tract infections. It has been found that the amount of estrogen in the vagina actually helps the good bacteria in the vagina, the lactobacillus. And when those lactobacillus or bacilli are there, they help to decrease the bad bacteria that can get into the vagina and then make their way into that short urethra and then make their way into the bladder. So having good estrogen effect in the vagina is important for bladder function, sexual comfort, and recurrent urinary tract infections. It's also been found lower estrogen levels can affect urinary urgency. What is urgency? Is that overactive bladder. Overactive bladder is diagnosed once all of the other conditions that cause fecal urination have been evaluated. For example, as I mentioned, urinary tract infection can cause frequent urination. Diabetes can cause it. So before we label somebody with overactive bladder, meaning that their bladder is going whenever it wants to go and not allowing us to control it, we have to rule out the other possible organic causes. So that's why it's so important to get an evaluation and not just get a depends. Somebody might have a live mic. Common symptoms: dryness, burning. The urine is acidic, and so if it hits an area of skin that is not it's not healed, but there's an open area, the acidity of the urine can burn that area, and so that may give us a sign that there's something going on in the vagina that needs to be looked at and evaluated. Leakage I've talked about, and then dyspareunia, painful intercourse. So menopausal changes are hot flashes, but there are a lot of other things here that you see that can go on. So genital urinary syndrome of menopause, GSM, affects all these areas in the women's urinary system: vagina, bladder health, and sexual health, which we've just gone over. These are the common symptoms that you might experience: dryness, irritation, pain with intimacy, and frequent urinary tract infections. A lot of times people will have a urinary tract infection. We treat it with antibiotics because there's a bacteria that's causing it. But going on for the prevention, a woman may actually need to have estrogen given to the vagina to help decrease the frequent urinary tract infections. So replacing estrogen to the vagina is not just for the dryness there or for intimacy, but it also is important in terms of decreasing urinary tract infections. Now, let me just stop there. So there is concern about estrogen. Taking oral estrogen has been linked to breast cancer, endometrial cancer, different changes, but What I'm talking about here is replacing the estrogen in the vagina. So the ways that we replace estrogen in the vagina, there is just absorption in the vagina, very little systemic or absorption into the bloodstream. So very little usual chance, I mean, nothing's ever 100%, but chance of it getting into the bloodstream as an oral estrogen might or as a injection might to be for concerns with breast cancer and ovarian cancer. So we're talking about vaginal estrogen replacement, not necessarily oral estrogen replacement for hot flashes and things like that. So the key message here is that painful intercourse is treatable. You don't have to live with that pain. You don't have to suffer in silence. It can be treated and very effectively. So here are some of the newer treatments for menopausal symptoms, some of the newer therapies. First, though, have a conversation with your physician and be truthful and honest and candid. Let them know your concerns, and if they can take care of them, fine. They need to refer you, follow up on your referral. Here, what I'm showing this upper picture here is that part of the menopausal symptoms that we can see that can be treated can be helped with what's called pelvic floor therapy. So in our pelvis, there are muscles in the pelvic area that go to help with making sure that we hold our urine properly, making sure that our internal organs are not dropping down or prolapsing down in the vagina. And a very common symptom of prolapse is pressure, or maybe even looking there and seeing a fullness or a bulge in the area. And what is coming down? A number of things can come down, but most commonly it's the bladder. It's due to the weakness of these pelvic floor muscles that hold it in and the nerves that are involved there for that. And it happens as we get older, also in men and women, but I'm commonly now speaking about women. So you need to, again, let your physician know and let them have an exam. I teach medical students at least 2 or 3 times a week. And it's just so important to first get the history from the patient, ask them, don't lead them with questions, but what they're experiencing, what they're taking, but to do the exam. I don't know. We seem to be getting away from exams. I hope we don't uh, completely, but we just seem to be ordering tests and ordering images. But the examination is so important. So have a look down, have a look see. Maybe you haven't looked down yourself with a compact mirror or something, but have your physician look down and see what may be going on. Now, and we can tell vaginal atrophy when we do exam. We can see vaginal prolapse. What do we see with vaginal atrophy? We see a loss of the normal rugae or the folds that are in the vaginal tissues, and we see a thinning of the vaginal tissue. So a lot can be seen on inspection of examination. There are some over-the-counter steps for remedies for vaginal dryness that's mentioned also here in this slide. Just adjusting your diet, drinking more water. So these are all sort of home remedies and things that you can use. There are also vaginal inserts. So coming down here, again, replacing the estrogen to the vagina can be used by placing an insert that has a medication, DHEA, a suppository insert, or an estrogen tablet insert. And you see the type of what's employed to place this up into the vagina. And that's going to then be by the body heat, body temperature dissolves. And again, just the effect here on the vaginal area. This represents here your bladder, your urethra. So again, hopefully a helpful effect on the bladder for overactive bladder, the urethra for preventing the UTIs. If your uterus is still in place, sometimes we have to look at a different way of giving estrogen, not just pure estrogen by itself, but adding estrogen to progesterone so that we don't necessarily activate the cells in the uterine lining. But what I will tell you, if you are started on this treatment and you develop bleeding, then again, you should see your physician, and you go back and discuss that with your physician. You shouldn't have bleeding, gross blood in the vagina after being started on estrogen cream or DHE suppositories. And some of these suppositories and things can be compounded by a pharmacy. So a lot of times some people can get them without a prescription. But as I'll say in talking to men about testosterone and estrogen, the prescription medication, we know how that works. We don't necessarily sometimes know how some of the over-the-counter things work. Or so just because something says that it's natural doesn't necessarily mean that it's safe. And I'll go into that more. With respect to hot flashes, there is a new non-hormonal option called Veosa. And I will say in this presentation, sometimes I will refer to the brand name because that's what you'll hear most commonly. If I was doing a scientific presentation, I may use the generic name, but here, Veosa, they're starting to do a lot of advertising on television now. So this now indeed is a pill that you take, but it doesn't have hormone in it, doesn't have estrogen or testosterone in it, but it does help its mechanism of action with hot flashes. So we're not talking about taking in an estrogen pill. And so again, in terms of having to worry about breast cancer or endometrial or GI gynecological cancers, it's a non-hormonal option for hot flashes, Veosa. The benefits, of course, having those fewer hot flashes, also improvement in your sleep. Again, sleep is, well, it used to be so underrated. I know I keep hitting that, but we're starting to go back to how important sleep is. And then, like I said, there are hormone-free options if there's a consideration. So if someone has had a history of high-grade breast cancer, any breast cancer at all, and there's concern that we might be activating some cells that we don't want to, then these newer non-hormonal options are preferable. Now let me go to the next slide. All right, so women's health, sexual health, female sexual health. You're not alone. 43% of women that have been polled have some signs of female sexual dysfunction. I know we've, concentrated a lot of men, and there's no real Viagra for men. They tried to use Viagra in women, and we're just a little bit more complex in terms of just trying to increase erectile tissue. Even the clitoris has erectile tissue. I had my patient said the little man in the boat. I don't know if you guys have heard that, but that's our clitoris. But Viagra really is, there's no women's Viagra pill right now because there are other issues with sexual dysfunction in women. There's desires of disorders. There's arousal disorders. There are orgasmic disorders. And then, of course, the pain disorders is probably the most common we see. But just look how high here desires of disorders are, just wanting to be sexual active. I mean, studies we've done in men is, I don't know what the most recent, but it used to say that sometimes men might think about sexual activity 100 times a day. Well, it was much lower. In women, that desire for intimacy was much lower, but it's still there after 50, right? I don't necessarily have to see a show of hands, but I would put my hand up, There's still a desire for activity. So, but all these different concerns cannot be treated with one pill. And even a man can't all be treated with one pill like Viagra. There are different things that have to be done. So, but there is treatment success, and these things they can be treated as I'm hopefully showing you and getting you to know about this. But these are some of the contributing factors. Stress has has a lot of undesirable effects, and the more that we can really stress in our daily systems, the better off we're going to be. Chronic illnesses. There are medications that have side effects, and I'll show you some of the urinary medications that we use that have side effects that can decrease sexual pleasure in both men and women, and then overall emotional health. So the key message, sexual wellness is healthcare. I say myself as physicians and those coming on, we are starting to incorporate this into our medical school teaching that it should not be a taboo topic, but it should be brought up. It should be talked about topic. And hopefully we're starting to do that. Treatments for low libido in women. First thing, counseling, talk to your physician. The pelvic floor therapy that I mentioned before, that just increasing, and it's not just doing a Kegel exercises, it's more than that. And sometimes you might even need a personal trainer who has been educated on how to tighten the muscles of the pelvic floor. Some of that you can see with just doing Pilates. If any of you all do Pilates and any type of yoga, a lot of those activities help with pelvic floor therapy. Testosterone therapy in selected patients. We actually sometimes do prescribe a small amount of testosterone therapy to women. Again, this has to be monitored. Testosterone can have other side effects, can affect the heart, can cause swelling and edema. So it's not to just be taken lightly. And I'm not suggesting that you go out and get testosterone over the counter, but that you just speak with your healthcare provider regarding this. These other ones, Phil Bannerseven, and some of these can be even more difficult to pronounce than what they really tried to treat. Brimelinotide. This is, you might have heard it called, commonly, it can be caused as Vyleesi is the brand name, or Elisa is the brand name. These medications, and this one being the number one prescriber, they are prescribed, which means now I know, we can think different things about the FDA, but it does allow medications to come through proper channels, proper working to see how they work in certain populations, how they might also work with other comorbidities, how they might work with other medications. You don't get that when you buy just an over-the-counter bottle of something. And remember, the over-the-counter bottle, if you really read, and you should read the ingredients, what does it say at the bottom? This product is not intended to diagnose, treat, or cure anything, really. Some of them are just high-dose vitamins, and if you take them in the proper form, you shouldn't have any problems. But if you're a transplant patient or on different medications, again, you wouldn't want to just take something counter with on through the scrutiny that we put medications through with FDA approval. So 7 ways to improve sexual health in older women over 50. Getting a good night's sleep, so important, 6 to 8 hours, eating a healthy, balanced diet, practicing meditation, making sure that you're doing your Kegels well. This may be a little difficult here, but if you need a physical therapist, there are trained physical therapists that help with pelvic floor activity. Checking your hormone levels. We can actually check with blood your estrogen levels, your testosterone levels, at least levels that have found to be should be normal in women. Exercise regularly. What is regularly? Well, after you get, again, cardiac evaluation to make sure that you can walk a block without being short of breath, you don't have any underlying heart problems, diseases, probably 3 times a week, at least 30 minutes a day, different types of exercising, and then doing yoga. So important, as I've mentioned here, in terms of treating low libido in women, these are and some of these options are just basic options. They don't even necessarily require giving a medication for that. So let me move on. So we're going to go to men's health section. So guys, and the men out there, low testosterone levels and men's health. A lot about low testosterone, a lot of advertising about low testosterone levels. Well, what do? They certainly can reduce your overall libido. They are important and needed for your erectile function, and they can cause mood changes. But as I mentioned, testosterone is a medication that should be prescribed by your physician. It should not, there are the over-the-counter treatments that I talked about. You really have to have caution with them. They really should be discussed with your physician, your primary care doctor. When you take in exogenous, meaning when you take in testosterone from outside sources over the counter, your body sees it and it actually says, you're taking in testosterone. Well, I guess I don't need to make any on my own. So there's a feedback mechanism that goes in, and it causes your body to stop making its own testosterone level. And then what do we see? What we can see is that overall reduced libido, also overall decrease in the size of your testes or the balls in the scrotum. Overall over time, actually a decrease in erectile function. So initially you might think, oh, I'm taking this over the counter, I'm feeling better, what's called a placebo effect for about 4 to 6 weeks. But then over time is a negative effect. When we do, and also associated with low testosterone muscle loss, and we see this in men commonly, but also in women too. And I'll talk about muscle loss with respect to our new weight loss drugs. But in any event, these are all different things you can see, of course, with low testosterone levels. But in the bottom part of the slide, there are ways that testosterone can be replaced effectively under a physician's guidance. I mean, testosterone is such a medication that can cause issues. Do you know that we actually have to give you a prescription and we have to put our DEA number, almost like prescribing a narcotic when we do prescribe testosterone therapy. So it's not to be taken lightly, but we can give it, replace it with pills orally. There's also sublingually using drops, transdermally. There are different creams and patches and gels. And I would just say, ladies and men, be aware of this because when you do put a cream or patch on, you may not necessarily want to just go right then and have sexual activity or intimacy because if this can rub off onto your partner, your female partner, and they can actually become it can also cause changes in them to the point of maybe causing development of like a little mustache or, hair increase in the areas of the body that we don't normally see. That is called transference. So when one medication as the skin is transferred to another person, that is not meant to go on. So when you do use the patches or when you use the gels and sprays, first put them on after you take a shower, because if you put them on, take a shower, they're going to come off. And then make sure that you don't have any intimacy with another female partner for at least an hour to make sure that they're totally absorbed into the system and maybe even waiting 2 hours so you're not transferring the medication to someone else. There's also injection therapy that can be done. With injection therapy, it does cause a boost in the testosterone level initially, but once that injection wears off, then there's going to be a lowering of testosterone. So it's kind of a roller coaster, but it can be given at certain intervals as injection. And then there are pellets, again, that sometimes can be inserted transurethral to help replace testosterone. So monitoring is essential. When do we monitor? The best time to check testosterone levels in men is before noon. They have a circadian rhythm where they're highest in the morning and lowest in the evening. So if I have someone coming in and needing to get a testosterone level, I like to check that first thing in the morning and see what your initial level is, and then also monitor you while you're on this therapy. Let me try to move along here. ED, of course, is common and is treatable, but the one thing remember about erectile dysfunction, and it could be anything, not just not being able to get an erection, but also low desires, not being able to maintain the erection, not having a proper orgasm, things like that. But it is a symptom of something else, usually 90% of the time. We used to think, oh, it was psychogenic. That's probably only 10% of the time, but 90% of the time, it really may mean that you have underlying diabetes or hypertension. I've had people come in with erectile dysfunction and they have, unbeknownst to them, high blood pressure, heart disease, obesity, again, and stress important. There's also penile abnormalities, one of which is called Peyronie's disease. Now, here's a pictorial. Peyronie's disease is named after Mr. Peyronie back in the 1800s, had this disease himself. Of course, why not name it after yourself, right? And now you're known forever and ever. But Peyronie's disease is when, so here a picture of the penis, and inside the penis, there are three channels. There are two channels that are big, sort of like big veins that allow the blood to flow in for a direction. And then after orgasm, the blood should flow out and the erection should go down. But in Peyronie's disease, these fibrous plaques develop in this tunic covering of the corpora, of these blood lakes, bodies of where blood flows in. And when these plaques develop, and we don't necessarily know why they develop, sometimes they're related to trauma or radiation or different things, but these plaques develop. And so once that fibrous plaque develops, blood is not flowing straight through to the penis. So what happens where the plaque is, the blood isn't flowing there, so the penis curves or bends. So I'll ask people, what side does your penis seem to curve to? Now, there's commonly men can have a slight curvature to the penis, but when it becomes excessive, where you cannot penetrate your partner, there can, on examination, again, importance of the exam, we can feel, and sometimes even yourself, you might feel this plaque. So this plaque doesn't allow blood to flow through. So the penis is going to bend to the side of the plaque because it's not getting blood flow through there. Now, there are treatments now for Peyronie's disease. Again, you'll see some advertising on TV about this, but there are things where we can inject the plaque to break it up. Sometimes if it's diffuse, we can surgically remove the plaque. But if you find, and this is probably less, about 10% of men who have erectile dysfunction can develop Peyronie's disease. But if you find yourself that this is a possibility here, then, again, seek your doctor's attention, and you probably need to be referred to a urologist. So that's one of the abnormalities that can be seen on exam and felt. But as I've mentioned, these are all the underlying things with erectile dysfunction. Now, there are many treatment options, and we know the most common one we all know about oral medications, commonly Viagra and Cialis. And let's get into those. But there are also vacuum pump devices that are placed externally on the penis to create a negative pressure to allow blood to flow into the penis to maintain erection. There is injection medicine into the penis. There's also regenerative therapy. Again, the use of injections, you have to be taught where you want to put that needle. I mean, you want to put it into this blood tissue called the corpora cavernosum. You don't want to put it into your head of the penis or into the opening or the urethra. That's the corpus spongiosum. That's where your urine tube is. So putting it in the urine is not going to be helpful. You have to be instructed on how to use the medication properly. And then there are penile implants. So this is saying from least invasive to most invasive. Sometimes people will come in and the first thing they'll want to have is a penile implant, but sometimes you might want to explore some of these other options before you go, because this is a penile implant is a surgical procedure. So when an implant or a prosthesis is placed into the penis to help maintain erections. Now, again, it doesn't do anything for your libido or your orgasm or anything. It's basically making your penis hard for sexual activity. It's going to be placed into this corpora cavernosa tissue. Okay, so this tissue that you initially were given for the blood to flow into, now the implant is going to replace this tissue. So once you have the implant, you're relying on the implant for your penis to get hard. You're not relying on the normal blood flow into the tissue because it's been replaced by the implant. And there are two corporal cavernosa tissues just showing half here, but there are two, one on each side. There's only one corpus spongiosum commonly only one urethra. But so you have a cylinder placed into each corporal cavernosa tissue, and then it can be inflatable, where you have a pump all this is hidden underneath the skin inside the scrotum to pump up the implant, or they can be malleable, where you can bend up or bend down when you're ready to have sexual activity. But again, the key important point here is to remember is that erectile dysfunction may be an early warning sign of vascular disease. So don't just think, again, I'm going to reach for that Viagra or the Cialis, but get evaluated. So weight loss and hormones. I hope I'm going to go a little bit over. I'm sorry, it's my fault we started late. But weight loss, all the rage nowadays, weight loss medications, and they do, are showing promising effects. The problem is that they haven't been out long. We don't know the long-term effects of these weight loss, 10 years, 20 years. But what we do see that we know in general that being overweight, can affect your testosterone levels, your libido, your energy, your confidence, and also play a part in urinary leakage. It's been shown that when you're overweight, if you have urinary leakage, if you lose 10% of your body weight, that can be shown to help improve urinary leakage. So healthy aging includes maintaining strength and wellness. Let's look at these weight loss medications. Okay, so here again, I'm just the common names. I'm not promoting any of these. I'm just showing you because you'll hear these names versus these are the brand names versus the generic names. But these GLP-1, now we have GLP-2 classes, weight loss medications, new weight loss medications. They're here showing, they're given subcutaneously. You could be shown how to give the medication to yourself. Very, very small needle caliber, different areas where they're injected and how they're used. And here's a couple that before and after. Certainly, lovely couple before, but look how with the weight loss medications over time that they were able to lose weight, and hopefully that helped to improve some of their life with respect to what we're talking about today. Just being together, exercising together, living together, sexual intimacy, just overall how these drugs, they've also been found to help with mental issues in terms of sleep, maybe in terms of Alzheimer's and dementia. I mean, it's just a number of things that these weight loss medications are showing to be helpful, but long-term side effects, this is what we don't know. And there's some people that shouldn't be taking them. If you have underlying thyroid medullary conditions, for example, you should not be on these. But the benefits certainly are there. Just weight loss, better diabetes control, and improved mobility. Weight loss and sexual side effects. So some patients did report better energy, libido, better erections, but then there were others that said they had reduced libido, fatigue. I don't know if anyone here has been on any weight loss medications, but the other big issue that we're seeing now with these medications is that people are losing weight, but they're also losing muscle, and muscle matters. So if you are going to be on these medications, you do need to make sure that you exercise, use minimally small weights. You don't need big weights, but with your exercise that you're using smaller weights to help maintain that muscle mass. So healthy weight loss should preserve muscle and strength. Muscle matters after 50. Important strategies: use resistance training, walking. Protein intake, again, you have to look at your own particular condition. If you are on a low protein diet in general, based on your kidney function, whatever, that has to be taken into account. We're talking about using smaller weights, not necessarily larger weights, getting the proper hydration, drinking the amount of water, and the proper sleep. This is really important for both men and women after menopause, lowering the estrogen, and also men when we lower the testosterone levels. Particularly, you'll see this in treatment of prostate cancer because we know prostate cancer cells are somewhat fed by testosterone. So to control that, we will put patients on medications that lower testosterone levels. And then again, the GLP-1 medications seem to decrease muscle mass. Medication education section. Let me just go through that. We have about 10 more minutes if you guys can endure. Medication education after 50. So there are changes that happen. Here's a depiction of the younger kidney and the older kidney. What happens there, that size, just the overall size of the kidney may change. The glomeruli, or the cells that actually are protective and not allowing protein to spill into the urine, change in size. How they work, everything changes in size. So as we age, kidney function changes. Drug metabolism slows down and medication sensitivity increases. So be careful when you're reaching for those medications and doing those different things. There's increased risk as we get older for falls, confusion sometimes, side effects of medications, dizziness, and drug interactions. This is an important one, especially when if you tend to want to take over-the-counter medications. Remember, not because it's natural or organic doesn't mean it's safe. The Beers criteria is the Beers criteria looks at medication safety, particularly in older patients, and there are certain medications that are on the Beers list that should not be taken by geriatric patients in particular because of their side effects. And so they can potentially be inappropriate medications. The American Society of Geriatric Psychiatry has listed this. You can look up Beers criteria. But what is the problem with these? Because medications, when you take them, the way they work is that they work on receptors, and some of the receptors are found in all different areas of the body. So if you're taking medication for your bladder receptors, some of those receptors, they're called muscarinic receptors, are also found in the brain. So the medication may travel there, and if it crosses the blood-brain barrier, for example, then you can possibly have these problems of confusion, memory loss, falls, constipation, and urinary retention. Anticholinergic medications are commonly used for bladder. So keep in mind that these medications can affect both the bladder and the brain. So I sort of use this ABCD. Anhidrosis is dryness that these medications can cause. And these are the common ones: oxybutylene, tolterodine, sulfenacin. Dryness of your mouth, blurred vision, constipation, because they're working on receptors to help your bladder to hold more urine, but these same receptors can be found in the bowels. So then what happens? The bowels hold more stool, leading to constipation, and then dry mouth. So again, just going over the possible side effects of anticholinergic medications need to be taken into account. So medicines can be used for the bladder, but they can also have an side effect on the brain. There are some newer bladder medications that are out, and they do advertise. This direct-to-consumer advertising is here to stay. Um, I would say in most ways I do like it, but I do want when a patient sees, for example, this little guy in the pink that's supposed to be your bladder and he's carrying your bladder along, that you do talk to me, do talk to your physician about it. I think it's good information for patients, but well, you can't get them anyway without a prescription, but it's good to have a consultation. So some of the newer medications, Myrbetriq and Gemtesa, these medications, the way the receptors they affect are commonly at the dome of the bladder, so they're not common receptors that they are actually beta agonists versus the ones I talked about, the anticholinergics. So they less commonly cross the blood-brain barrier to cause some of those side effects, but they do. I mean, there's no medicine that doesn't have side effects. I mean, aspirin, if it came out today, it would probably require a prescription because it does so many things, helps it helps in terms of lessening the platelets, in terms of if we want a person to have their blood be not as thick, thinning out the blood and headaches and this and that, but so many things. So these medications, these newer medicines, they do help with bladder control, but they do cause less dry mouth and less cognitive risk, but they still need to be monitored. Why? Because they have been linked to changes in blood pressure, particularly Myrbetriq needs to be monitored. It comes in 2 doses, but it can cause increase in blood pressure. Gemtesa less likely to do so, but again, they do need to be monitored by your physician. Erectile dysfunction, some of you know the little blue pill and the little yellow pill. There's actually 2 other pills on the market. They don't have as much market share. I mean, it's called Levitra, and the other one, Stendra, but these are probably the 2 most famous ones, the little blue pill and the yellow pill. The difference between is the onset of action. So let me just stop there and say this first. These medicines themselves don't cause an erection. So you don't just pop a pill and you pop up an erection. What happens is when you get that desire that intimacy and foreplay and the reaction starts in the penis, these medications help to continue that chemical reaction. They help to continue what is happening. You get a release of a chemical called nitric oxide, and that nitric oxide causes vasodilation or enlargement of those blood vessels in the corpora that I showed you. So blood flows in and allows that blood to flow in for the erection. So that's how they're working. And so they help improve erections and better intimacy, but they can have some side effects, as I have mentioned here. And again, that goes back to the receptors where they're found. So for example, Viagra little blue pill is can the same receptors, the PD5 receptors are found in the eye. So sometimes people can have a blue tint to their vision. And so it's actually one of the ones on the Beers list, the medications that pilots should not be taking. Obviously, you wouldn't want them flying in the sky with their vision being having a blue tint to it. Make sure they know which way is up or down. They can cause nasal congestion, flushing, and headache. So just beware of this. The tadalafil, the yellow pill, similar onset, but the duration up to 36 hours. So this doesn't mean that you're going to have an erection for 36 hours, but this means is that with proper excitement, the foreplay that I talked about, starting that chemical reaction, for some men, 2 out of 3 men who take this don't have to take another pill. So some people use it, say, for like a weekend medication. You can take one pill on Friday night, you're still good through Sunday night. Whereas Viagra is about 4 to 5 hours, and then you have to redose it. These are the dosages and things that it comes in. And there can be dosages, I mean, for Viagra is up to actually 100 milligrams, so you can take 5 of the 20, but you have to keep in mind, again, your renal function and your liver function when you're taking these medications. We use the lower dose, and if your renal function is somewhat impaired. Uh, so the other thing to keep in mind with these medications is that they work best on an empty stomach. So you want to kind of avoid that nice dinner out, which is if you do have that dinner out, just keep in mind that with after you have the dinner, probably about 2 hours later, in terms of how the medicine is going to be best. If you're having a heavy carbohydrate meal, they don't get metabolized as well. Also, avoiding alcohol. The difference again with sildenafil and tadalafil or Viagra, this is Cialis. Cialis can be taken with a little bit, 4 to 6 ounces of alcohol, and probably will not impede its effectiveness. Viagra, again, probably should not be taken with alcohol or within an hour of taking alcohol. The one thing to keep in mind is never combine these with any type of nitrates or nitroglycerin or any medications that you may be taking for the blood pressure, because they themselves, again, working on these other receptors, can lower your blood pressure. And so you wouldn't want it to drop too low, because then you could lead to a problem, ultimately death if your pressure drops too low, but fainting and dizziness. So keep that. And the amount of alcohol actually increases these side effects when you take these medications. Over-the-counter supplements. So natural does not always mean safe. This product is not intended to diagnose, treat, or cure anything. Now, I will say there are some products that are natural that have this USP verification. Again, it's not ultimately it's FDA approved, but they have gone through some structured looking at it in terms of different populations and patients with different medications and things like that. But always check the ingredients, review the label, avoid unnecessary additives and allergens that you don't need. And ultimately, I really can't strongly suggest consulting with your healthcare professional. But these newer supplements are, again, supposed to increase libido, increase in testosterone, prostate health, and energy. And let's look at them. Supplements are not regulated like prescription medications. I had a patient come in and ask me the other day, they wanted to talk to me about taking Viagra with the other medicines. They weren't on any nitrates or nitroglycerin, so that was fine. And then they asked me about another medicine, Mojo. I was like, well, what do I know about Mojo? Well, let's talk about Mojo. Let's first talk about saw palmetto. Saw palmetto is something that we thought was going to be a good extract for people to take in terms of prostate health, healthy prostate health, but the research did not really pan out. The results were very mixed. But what we do know about saw palmetto, people do use it for enlarged prostate symptoms like frequent urination, incomplete emptying, going to having problems with emptying your bladder. but it can have side effects, stomach upset, headache, and there's a bleeding risk. So if you're on this and you're getting ready to have surgery or something done, you would have let your doctor know, they should know all the medicine, even over-the-counter things you're taking because of the risk of bleeding. But it has been touted to help with urinary health. And so some people are taking saw palmetto for that reason. There's also zinc and selenium. Speak to your doctor about these things first. These other supplements that initially were being studied for prostate health, but any supplement, any excessive supplementation may be harmful. Or if you have reduced renal function or liver function where your body is not going to metabolize or excrete what it doesn't need, that could be a problem. So speak to your physician, get blood work, get recommendations, what you need first. Just have a few more slides. Testosterone boosters, so I had alluded to Mojo. I don't know how many people, we don't have to raise hands, but think about it, have heard of Mojo. I mean, you can buy it at the gas station, actually. And this one here is the number one selling is liquid herbal blends. So what are these blends? What's in there? But it's one of the number one seller brand in the United States for people that are taking to hopefully help enhance their erections and their intimacy. And some people think of it as like an herbal Viagra. Well, it's nothing in its framework or like Viagra. Again, it hasn't been tested with other things that you might be taking medications. Some important concerns of what else is in this product, what are the other hidden things that are in the product that may affect other medications or drugs. There may be some stimulants, which is some of these are high caffeine derivatives. I will tell you when Viagra, the basic model of Viagra is caffeine derivative. So some of them could have steroid-like compounds in them. So this male mojo, just be careful with that. You can have some risk with your blood pressure, drug interactions, and heart complications. In the last 10 slides, transplant and kidney health, special considerations, medication safety. I know I'm probably preaching to the choir here because Dr. Callender has taught you guys throughout the years different things that you need to know and do, but hydration, infection prevention, hormonal changes that they can cause, and just sexual health. So again, if you see any of this, blood in your urine, fever, pain with urination, report. These are warning signs that need to be reported right away to your physician. Some modern urology advances, well, we certainly have advanced our surgery with respect to prostatectomies, removing the prostate or kidneys and bladder with robotic surgery. In terms of, we're using now more commonly the MRI guided biopsy. I will just speak to that. I mean, the MRI is a three-dimensional imaging test to look at abnormal areas in the prostate and to more target our biopsy needle so that we get the area of interest if we need to make a diagnosis of prostate cancer. Like before, we would use, we didn't have targeted biopsies, but I personally feel that this should not replace the digital rectal examination. I will say, though, for prostate cancer screening now, it is very well accepted to just have your PSA blood test done. I will take that over not having anything done. I sometimes like to do the digital rectal as part of my examination of the patient as a whole, but I will say, as we train doctors now coming through that don't do digital rectal examinations, if you don't know how to do one well or know what you're feeling, you probably shouldn't do it. And probably, unfortunately, we're going to rely more so on the PSA blood test. And then if the PSA blood test for commonly in people, men over 50, they shouldn't be higher than 4. Certainly, if you're under 40, it shouldn't be higher than 2.4. But be that as it may, it's going to trigger you now to get an MRI. And then once the MRI is done, then look for areas that may need to be biopsied. There are newer laser procedures, particularly for enlarged prostate, and also women laser procedures if there's evidence of any vaginal adhesions or labioplasties, different things that can be done to help there. And a lot of these are minimally invasive procedures on the prostate gland that don't require a roto-rooter or a TURP. It can be just as minimally as putting something in to kind of stretch the bladder opening in the prostate to allow better flow of urine. It could be something you've probably seen the the ProLift or the Urolift system to lift up the angle between the bladder and the prostate to, again, help urination and resume. So there are many minimally invasive procedures coming out. And the benefits is that faster recovery, usually less pain, and usually incisions, no incisions or small incisions, all can be done transurethral. So healthy aging tips: enjoy life, you know, no smoking. Smoking harms the urothelium or the lining of our urinary tract, and that change can stay even when you stop smoking. So unlike lung cancer, if you stop smoking, you do decrease your risk somewhat of developing lung cancer. But once these changes occur in the urothelium or the lining of the urinary tract, it does not necessarily reduce your risk for getting, for example, bladder cancer or urothelial cancer. Drinking water, we could probably talk another half hour about what type of water, how much water, things like that. But just our water, our bodies are two-thirds water, so we need to replace that. Monitoring your blood pressure, maintaining your muscle strength, controlling your diabetes and blood pressure, stop smoking, reviewing your medication list regularly, and discussing your sexual health openly. Feel comfortable with talking about that with your partner and your physician. There are myths and there are facts. Sexual problems are normal aging. Well, okay, perhaps, but as I've shown you hopefully today, many of them are treatable. Natural supplements are always safe. No, supplements may have risk. What's in them? What are the additive features? Painful intercourse is normal. No, it deserves evaluation. There are treatments out there for it. And ED only affects older men. No, ED can be a signal for underlying vascular disease. And there's actual sexual dysfunction or function that we find in women, not just men. So future of urology and sexual medicine, I think it's exciting. We're coming to know some things that used to be tattooed or not talked about, but now hopefully we're talking about these things. And only in talking about them are we going to be able to find options to help with treatment, maybe even cure. We can perhaps in the future personalize hormone therapy by drawing your blood levels for estrogen, testosterone, other hormones. We can maybe personalize the therapy more. There are better menopausal therapies that they don't all include hormone therapies for, say, hot flashes. There are non-hormonal treatments for hot flashes. Certainly, AI is here. AI-assisted diagnosis is here. You know, it used to be Google. You put everything in Google, and Google tells you. Dr. Google tells you whatever. Well, there's still going to be a role for physicians. There still needs to be someone that needs to coordinate all this. And AI can have its hiccups. You've probably heard how AI can malfunction. It can hallucinate and all kinds of things. So, but it is here to stay. And I do think it's a modality that can be used. There's regenerative medicine in the future, looking at how we can actually replace these cells, regenerate the cells for improving sexual health. And there's expanded sexual wellness care. There are expanded clinics and different things. And I'm sure maybe many of you may not have known the importance of sleep and the importance of pelvic floor muscle activity and exercise. So I'd like to thank you. I'll take any questions, any discussion. Healthy aging is not just about living longer, but it's about living better. So on that, thank you very much for your attention, and I will entertain any questions or comments.
Well, thank you very much for that superb and very comprehensive presentation. Wow, it was awesome. Let's see, we have Darryl and Carol Tatum have questions.
Okay.
Dr.
Carol?
Coleman, thank you so much for that
Darryl.
wonderful presentation. Great information. And I like it that we're emphasizing that the best way to live our best life at this stage is by doing things like maintaining a healthy weight and exercise.
Yes.
Okay. A couple of things that I'd like to be included.
Have a great day.
Sorry, my wife is going to work. I had to kiss her goodbye.
Oh.
Okay. For urinary tract infections, we didn't talk about, modern clothing trends because, my thought
Mm.
was that um, dresses and skirts are better than pants, tight-fitting clothes, leggings, because they stop airflow and
Mhm.
in synthetic fabrics. So I like to get a shout out for that. Um,
Yeah. Hmm.
and the other thing is that with sexual activity, is that alcohol is never an aid. Can contribute to vaginal dryness, decreases sensitivity.
Hmm.
So, I think alcohol is probably never a good thing as it relates to sexual health, except for it can remove some inhibitions. It
Hmm.
can get things started, but things don't end up as well with the presence of alcohol. Your thoughts on that?
Yes, I agree with you, Darryl, for sure. Frequently tell my patients, men and women, to be careful with tight clothing, and like I said, allowing the air to breathe. Also, there are conditions in men, for example, um, sometimes enlargement of the scrotum, extra fluid in the scrotum, or a hydrocele, where there's pros and cons. Some people, sometimes if the hydrocele, that fluid gets to be very much enlarged, they usually require aspiration or surgical treatment. But just in general, or just supporting the testes with scrotal support, versus the jock strap. So it can be an individualized thing. But yeah, clothing is certainly important there. And alcohol, you're right. I mean, it is removes certain inhibitions, but certainly you drink too much, you probably fall asleep or get yourself sick. But it does interfere with those medications I talked about, Viagra, little blue pill, and Cialis. It does interfere with your medications that you take in general. And there should be a limit, 4 to 6 ounces, but probably not going over that. So yeah, your comments are well taken. Thank you. I see Carol, I think, was next.
Thank you for the presentation. It was wonderful. I have two questions.
Yes.
One, what what do you suggest for people that do not have a sexual partner or their mate has died and all of that? And what about sexual behavior when someone has a heart problem? I've never heard that referred to, if they might have a pacemaker or a heart attack. I've heard the horror stories of when couples are having sex and one will die on the other one, and that's
Mm.
a fear. So could you address those two things?
Yes, thank you. Yeah, that is the last one first. Certainly a fear. That was one of the fears that initially came out when people, before we started really understanding the little blue pill. You might remember that it was first advertised to, I think the advertisement included former President Bob Dole. And it was like, well, people didn't know. I mean, yes, intimacy, sexual activity is important, but you've got to be in, quote, shape for that. So I used to ask people, can you at least walk up one flight of stairs? Can you walk, one block? If you can't do that, the amount of power, things that involve in sexual activity is probably going to be more harmful for you than good to try and do. And so you need to get that straightened out first. And if I have patients that are on nitrates and nitroglycerins or have pacemakers, I first like to involve their cardiologist, so their heart specialist, to give me an idea of what is safe, and also for them an idea of what is safe for them to do and what medications they can or can't take or should use. Uh, the fear of someone dying on you is a very common fear. I hear it more commonly expressed by my female patients, I will say, than my male patients. Um, but it is certainly of concern. And so it does warrant um, review with your primary care doctor, if not even your cardiologist, to see what activity one can perform. So this may be involving doing an echocardiogram or doing other, special heart tests to see um, how much the heart can take, and just being aware, again, like I said, just a simple question. If you can't walk a block without getting short of breath, then that is a signal that something, we need to kind of take a step back. Okay. And people can engage in besides just intercourse. So that should be kept in mind, masturbation, foreplay, things like that, or just enjoying your partner on a good, dinner date. Um, in terms of sexual partner, if your partner has passed away or, you're not engaged in that anymore, that is interesting conversation to be had and should be had. You have to feel first, I think, comfortable with yourself, what you want to do. If you feel that you want to be more intimately involved, certainly that is good. Keep that in mind. And then make sure that you're on a path that, should you meet that partner, that you're ready to go. But it is it is actually another conversation, I think, maybe Dr. Callender, that we might want to think about having, because it's such an important. I am widowed. I say just personally in my own experience, and desire some time, just not necessarily intimacy, but just a partner, someone you'd like to go around and have fun and do things with. So it is an important conversation. So thank you, Carol, for bringing that up. But it is something, yeah.
On just one more comment, I have a cousin who's almost 90, almost.
Okay.
And she
Yes.
sort of scares herself because even in her 70s and 60s and 80s, she says she has very, well, okay, in the layman's terms, she's very hot and she desires
Mhm.
sex all the time. Her husband has deceased and she's just trying to figure out what she should do. She's had one boyfriend and he has passed. And so
Yeah.
there she is left again without a
Mm.
partner. So
Yeah, I mean, it
so
is
what,
certainly, I mean,
and my mother's old adage when she was in her 80s was just keep
mm,
yourself busy. Just keep yourself
you're
busy.
so busy. Yeah, well, busy doing what? But certainly we're living longer. I mean, it's not uncommon now I have, 70 patients in their hundreds, and some of them have good sex drive, and want to be active. And so I think, keeping yourself active is healthy. It's one of those parts of life, quality of life, and perhaps surrounding yourself. But I will say, um, in general, of course, to be cautious and prudent. In the early days of Viagra, we had an increased tick in nursing homes of sexually transmitted diseases. And maybe it was, maybe indiscretionary use of these Viagra Cialis and not taking on, precautions. Getting an idea from the partner that you're going to be with, what their history is, and use of protection, condoms, and things like that. So yeah, that is an interesting phenomenon that happened in those early days. But we do know that um, erectile dysfunction in both men and women, again, that is really a harbinger of something else going on that also needs to be looked into. Certainly, if you are with someone who is using a pacemaker or whatever, make sure that you may need to make sure you know how to do CPR, of course, call 911. I mean, sometimes these things happen. They may be incongruent with the timing of when they happen, but they do happen. So I'll take Lucille next. Lucille Perez.
I was going to let John Buchanan go before, since
Oh,
I tend
okay.
to talk a lot, and
Oh,
then I'll come after him if there are no other questions.
okay, great. I'm actually making a list of these things because I like this, what we're having here in terms of the next time. Yes, John
Yeah,
Buchanan.
Dr. Coleman, thank you so much. I learned so much from your presentation, and especially having estrogen made on our adrenal glands. I had no idea about that. And menopause in men. I think that's an interesting idea. But the questions, if you're on high blood pressure medication,
Mhm.
doesn't that affect your ability to have an erection?
Yes, some high blood pressure medication can affect your ability to have an erection. Yes, that is true. And so sometimes, again, in my evaluation, if people I ask for their medication list and I may see that on it. And again, now I have to be in consult with their cardiologist or their primary care doctor because perhaps they need to be on that medication and we cannot change it. So, for example, let's say if you're on a medication that already is lowering your blood pressure, it may not be prudent for you to go on a like a Cialis or Viagra or something because it's going to lower your blood pressure even more. I mean, Cialis actually has a dual indication. It can be used for erections. It also can be used for prostate health in terms of emptying the bladder because the way it works. So therefore, we may have to look at an alternative. Instead of those particular medications, we may have to think about the vacuum pump. Yes, it's a little bit more energy intensive to use. Maybe penile injection therapy. I mean, a lot of things now are coming by injection therapy, and one may think, oh, wow, putting a needle in the penis, but it is a smaller type needle. You have to know where to place it. I will say that it is one of the medications that can be riskier in terms of developing a condition called priapism, where it's an erection that is a bad erection, is abnormal erection that lasts more than 4 to 6 hours. And it's not one that it's not a pleasurable erection that you'd want to have for 4 to 6 hours. So, but you see it more commonly with penile injections than you see with Viagra or Cialis. So it's something to keep in mind. And then there's lubricants that actually kind of increase sensitivity of skin in the penis to help with that. And then, as I mentioned before, penile implants. But it's a surgical procedure. But it's one that was commonly done before the PD5s came out for erections. And we're kind of going back to that a little bit because not the Viagra and Cialis probably really only help about 2 out of 3 people. They're not 100% for everybody. And they do have, side effects and things. So.
And you mentioned about getting your testosterone level checked. You said a number of 4. I had heard 6 for some reason.
Oh, that's for the PSA. You're talking about the PSA?
Oh, the PSA. Okay,
Yeah.
yes.
Okay,
But,
so go ahead. I'm sorry, sir. Go ahead.
But the testosterone level, should I ask my physician to get my testosterone level checked?
Yes, I think you should, especially if you want to know. It's certainly tied to libido. So low testosterone levels we see usually associated with low libido, low wanting sex drive. And also for your muscle strength, also with low testosterone levels. So it's important to have it checked, best in the morning. The issue with testosterone levels is such a wide range. If you look at the normal levels for testosterone, it goes anywhere from about 250 to 900. Well, we're not necessarily expecting someone over 50 to have a testosterone level in the 900 range or 700 to 800. That would be more in a younger adult, but probably somewhere 400 to 600 would be what would be expected. So that's for testosterone. Now, in terms of the PSA or the prostate-specific antigen, this also correlates with age. So yeah, I know you mentioned, so normally the lab will say less than 4.0 nanograms per mil. Now, this correlates with age and also prostate size. So PSA is made by the cells of the prostate. It's an antigen that cleaves the semen to allow the sperm to swim freely to their destination, but it's not necessarily specific for prostate cancer. I mean, we use it for screening. But if you're in your 70s, it may not be uncommon based on the size. And this is where I think the rectal exam or some type of imaging of the prostate is helpful. So based on the size of your prostate, that your PSA may commonly be 6. It doesn't necessarily mean that you have cancer. We can do what's called the PSA density, where you take the PSA and divide by the volume of the prostate, estimated volume, gives us an idea what the density should be. And if it's greater than 0.1, that may be another signal of possible prostate cancer. But yes, the PSA can vary by age. It also can vary by the size of the gland. It also can vary by what's going on. Like if you check a PSA, someone just was very sexually active the night before or masturbated, PSA will be falsely elevated. If you just had a colonoscopy or something done and within the last week or two, the PSA will be falsely elevated. if there's infection, urinary tract infection or prostatitis, inflammation in the prostate, the PSA will be falsely elevated. So just having an elevated PSA does not necessarily mean that you have cancer. It does need to be taken into context with other examination findings, imaging findings, and symptoms. So,
Thank you
yeah.
very much. Thank you.
Thank you.
I just wanted to let you know that this is a fascinating discussion and should continue. I've got to leave, but just stay with Dr. Coleman until you
Yeah.
finish getting answers to all your questions. Because
Okay.
this is a wonderful session that is tough to compare it with anything else.
Well, thank you, Dr. Callender. Have a great day. I see Lucille. I was coming back to you, Lucille.
And thank you again. Outstanding. Outstanding. And it points to DEI. Having a woman start off talking about sexual dysfunction in women, I'm telling you, you are the best example of why DEI is so important. So, anyway, I am very, very excited. I know we talked about you coming back. I can't wait because the intergenerational discussion that we need to have, because Dr. Callender has us as disciples. So just hearing your conversation, I remember how uptight I was about talking about sex with my son, who's now 47 years old. But it's important. I want him to have a phenomenal sex life. I want him to enjoy himself into his hundreds. And I need to discuss some of the things that you're talking about because I don't believe him and his boys are doing it. And just like it was an issue with adolescents and talking to them, intergenerational discussions on this wonderful thing that the Lord has given us, sex, is so important. So I can't wait till you're coming back again for us to continue this discussion. It was off the chain.
Oh,
Off
thank you.
the chain. Thank you, thank you, thank you.
Oh, you're so welcome. Thank you. Thank you very much. Appreciate that. I'm making some comments here to incorporate next time. Thank you. See Carol?
Yes, I wanted to know about, I know of several instances, probably more than several, where it was the female that lost interest in sex and had gone for years being married and their partner try to get help, try to understand. But they were basically having sexless marriage. Do doctors ever address this? Or I know they don't do this in public, and I thought at first it was rare, but then when I kept hearing incident after incident, and men very seldom will say anything to anybody when their wives are not performing. So, your thoughts on that?
Yes, thank you for that. So you might recall the slide I showed about the questionnaire that was sent out to women in sexual function. And I think, again, on the complexity of with women, and not to say that men aren't complex either, but just on talking about sex and different things that happen to our bodies as we age. Um, and just just sort of try to get rid of the tattoo there of some of these things. Some women and I think that not all physicians are comfortable talking about this topic, talking about a lot of different topics. I'm not orthopedist. I'm not going to, if you have hip pain, I'm going to say I got to stop there. I'd refer you to somebody who can talk to you about that. But I think that interesting enough, next week is our AUA, American Urological Association conference. It's here in Washington, D.C. And there are more topics on sexual function in women than I have seen in my 40 years of practice, 45 plus years of practice in urology. And it's coming to the forefront. And now, if people don't feel comfortable, then perhaps they shouldn't see those patients. But they should be referred to a doctor that is comfortable. And there are women, and even in this area, it's very good in this area that I know of one particular female doctor who that's all she does in her practice to see women and discussing sexual function, treatment options, different things available. I mean, who would have heard of taking testosterone? Small amount, not a lot, but to help with driving libido or the effects of why the dryness is in the vaginal area. And sometimes these are like hidden things that women will carry. Um, Sometimes they'll to support their husband will talk about. Now, I didn't even go into transgender issues. That's another topic, but you know, bearing on the pain of sexual activity when they're uncomfortable. Vaseline is great, but it doesn't just stay there long enough. There's also replens and lubricating jellies over the counter, but all these are trying to increase that wetness there. But the actual what's needed is what's lacking is the estrogen. And so how can we give that safely without, having other issues? So it, it it's something that we need to go and feel comfortable talking to our doctors about. But I agree with you, and I think Lucille, someone else said the physician sometimes has to bring it up. I will say, for example, I will see a patient and I think I'm finished. I'll just say I'll pick on the men for this one. I think I'm finished with my examination and talking about prostate health, and I'm walking out the door and get ready to my next patient, and they say, can I get that little blue pill? Well, we didn't discuss the blue pill. There's a lot that we need to talk about that little blue pill. It's not just a, peppermint candy supplement. So I think I say this to say that at the end of my conversation, I try to say, is there anything else you want to talk about? And then I will try to say, how's your sex life? And some people say, well, I'm fine with it, or I'm not fine with it, or, oh yeah, I'm glad you brought that up, and maybe we need to take time to discuss it on your next visit because we've, ran the 15 minutes that I've been allotted to talk to you about it, but about other issues. But I mean, I think that both the physician and the patient, and I also encourage people to come in with their partners. Again, we have to allot the time for that kind of discussion, but it's so important, or discussing independently with one partner versus the other and trying to get an idea. Now, this can go on to sex counseling and things like that. I'm not, I don't have a degree in sex counseling, I will tell you that, but I would like to think that I try to be open to what people want to discuss. And because people are living longer. And so sex doesn't stop at 50, 45, or 60. Like I think Lucille said, well into your hundreds. I mean, there are people that still have a good sex drive. Even though they're, 95 years old. I had a couple that just got married. A friend of mine, I think he was 89. He was younger. She was older, I think 92, something like that. Anyway, so it's not, it doesn't end. It goes in, and it's part of life. It's part of living. It's part of quality of life. So, yeah. Okay. Are there any other comments? I see Darryl. Yes, Darryl.
Okay, my comment was there's a lot of ads on TV and radio about blue pill and yellow pill where they have online doctors that will approve a prescription. And people think that they can, okay, what may happen is that they get a prescription from their doctor, they go to CVS or Walgreens, and the charge to their health insurance company is several $100s for a prescription. And so then they go online, and maybe it's half the cost, but it's still very expensive. But there's another option, things like GoodRx, that could bring the cost down to $15, $20, just depending on the dosage. So that's a very good alternative. The other thing is that for increasing testosterone levels, one of the best natural ways to increase it is through resistance training, such as weightlifting. And the most effective exercises for that are going to be the high intensity ones like squats, deadlifts, and bench press. Uh, Bench press and deadlifts can be safer. Well, bench press can be safer because the body is more supported. If you have a bad if you have some back problems, you have an unstable back, deadlifts can be a problem. The same thing with squats. But if you're able enough to do squats, then that's the most effective way for increasing testosterone from what I know. And what do I know? I'm not a doctor.
Well, you know what you know, and I learn a lot from my patients. I learn probably more from my patients sometimes. Like I never knew about the little man in the box until when my patients told me that, the little man in the hood, whatever it is. But anyway, I learn a lot from my patients, and you're very right. You're very correct. Squats is a really great exercise for people to do done properly. Of course, that's is where personal trainer watching you do your squats and make sure you're doing it properly is important. And of course, before doing all of this, making sure that you can exercise without issue. But resistance training is important, as you mentioned, smaller weights, faster, not, you don't necessarily need to bench, lift 200, 300 pounds or whatever. You don't need to do that. GoodRx, we keep GoodRx cards in our office and I hand them out. Sometimes I have to do a little tutorial on people on how to use it. And the one thing I'll mention there's another company besides GoodRx, I can't remember, but we use commonly GoodRx. But you do need to have the prescription with you. So if people want to use good, because you have to have the prescription if you want to sort of shop around the different, and not all pharmacies charge the same. And like I said, there are these companies that advertise late night. I'm up at night doing my PowerPoint presentation, for example. And so I see these advertisements on, call this number. I guess there's a series of questions that you have to answer. And then if you answer them a certain way, whatever, they will prescribe you the little blue pill or yellow pill. I often wonder if those are, quote, the real thing. I mean, you can buy on the street these drugs. I think five was like $25 or something. My patients tell me it used to be. Maybe it's gone up now. But now, are you getting the right thing? Are you getting what you want? And are you under a doctor's care or taking? I mean, that's really the main thing, taking these things. Um, so anyway, I think that's out there. There's marketing. I mean, there's a company that used to market here in the DC area, make a consultation with us. And, when you leave out of here, you'll have an erection. That's pretty much when you leave out, you get a penile injection. That's why you'll have an erection. But the company that was actually using this, they were pediatricians. Not to say anything about pediatricians, but they weren't even necessarily urologists that were promoting, dispensing medications uh, for men for ED. What I found is that I would see they would dispense like a little bottle, let's say a medicine for penile injection, not really clearly talk to the patient about the pros and cons of this, and the patient then ends up in my office with issues. But what I will say is that I think that why did a person go to such a website or go to such a place? Because it wasn't maybe discussed in the doctor's office. Like they'll say, well, I didn't know my doctor could prescribe this. Well, maybe not your primary care doctor, but your doctor should know a urologist that can prescribe this. So without having to go to the streets to get your prescription. So I think that's where we fail in the medical community of not bringing this subject up. So the point well taken. But yeah, there's certainly a lot of marketing in it. So I see Janice.
Yes, hi.
Hi.
I just wanted to sum it up by saying thank you, thank you. You're an excellent speaker, very thorough. And you touched on a particular subject that a lot of us, I think, have had questions about, but wasn't comfortable asking. You made us comfortable. And definitely, we would love for you to come back and share more topics with us. The sexual activity of seniors is something that, in my mind, had been pretty much taboo. And Carol touched on the subject of losing a partner, a senior person losing a partner, future activities. Very interesting conversation, very interesting. I learned a lot. Thank you.
Thank you. Thank you. And I welcome coming back and let Dr. Callender know. And like I said, I've taken some notes and some other things I want to add in too, perhaps next time. And things are evolving. And, for the women out there, I mean, the men, you guys are ready with your Viagra. What are we going to do? We need to be ready too, right? If we're not ready,
Yeah.
then other things happen, whatever.
Yeah.
But thank you guys very much for your
Thank
attention.
you.
and have
Thank
a
you.
wonderful day. Thank you so much.
Outstanding. Thank you.
Thank you. Thank you.